So, a very good afternoon, everyone. So, I'll start with my topic without any delay. I'll just share my experience, what we have seen in the in this region. So, before that, I want to just brief something about the extranodal lymphomas. So these lymphomas are those lymphomas that occur outside the lymphatic system, means not in the lymph nodes or not involving the marrow. And these lymphomas can arise from the different organs, the extranodal organs. So most common site is the stomach and followed by skin and intestine. But most common site is the stomach, as we know. So coming on to the patterns of the extranodal lymphoma, so most common pattern is the diffuse large B-cell lymphoma. So very aggressive, will respond to treatment, but this is the most common type, followed by others, slow growing and other lymphomas. So what is the incidence? Why I have chosen this topic that should be discussed? Because the incidence is bit on rise now and is increasing in India also. As you can see on the screen, the incidence of extranodal lymphoma was more in the Italy. The reasons may be multiple, environmental and viral causes, different causes. But in India, the incidence was only 22%. This is a main elaborated format where we can see that these lymphomas, they have now different kind of incidents, more in Kuwait, lesser in the Thailand, and these incidents of the lymphoma is different with the different organs also. So different organs, they have different kind of incidents in the different regions. Now, what is the problem? What problem arises in India? In the North India, a very few studies has been there in the literature that those show that what is the exact incidence of these extranodal lymphomas. So one study shows that there is increasing trend. So they have mentioned that there is 44% 44% incidence of extranodal lymphomas amongst the patients, and they have done this study for the approximately 3 to 4 years. So, but in the South India, the study conducted for the same time has shown the same incidence as it was seen nationally. So it is only 22%. So, because of that, what we have observed in our area, because we were receiving patients with extranodal lymphomas, unexpected cases. So we have also tried to elaborate the data, to collect the data, just to analyze what is happening over here. So in our region, in our area, because we are draining patients for Punjab and Haryana and Rajasthan, so in our area, what we have seen that incidence is 31.25%, and let me tell you, this is just within 1 year. Okay, so patient age range you can see starting from 9 to 83 years, and median age is 67. So over here, what the difference is that patients are presenting with extranodal lymphomas in the very early age also, and that is a bit alarming. And more commonly, the patients were more in the cases were more seen in the males. So here we have collected few cases who were, I want to show that these are the cases who were rare, although extranodal lymphoma itself is a rare entity, but we have seen rarest of the rare cases. As in the first row, you can see 9-year female presenting with swelling over the left thigh. And initial diagnosis was given lymphoproliferative neoplasm only, because we were not sure that this diagnosis should be given to this or not. FNAC was done at PGI, and then patient was over here for the treatment. And even on HND, we couldn't make the diagnosis because we were not suspecting that Hodgkin lymphoma can present as a left thigh swelling. So on IHC, the lymphoma was confirmed as Hodgkin lymphoma. And next, GIT is a commonly involved site for the extranodal lymphomas, as I have already shown that stomach is more common, so I'll not discuss that. Liver itself cannot show like liver itself, most of the times not as a part of extranodal lymphoproliferative disease, but over here also we have seen this case, and it's a very low grade type of lymphoma. And on imaging studies also and clinically also, this patient was diagnosed as metastatic disease in the liver. Next is a nasal septum. This condition is also rising nowadays. On IHC and on imaging studies, the picture was looking like undifferentiated malignant neoplasm only. There's undifferentiated carcinoma of the nasal septum. So it was looking like that on histo also and imaging also. But on IHC, when we applied the markers, primary panel and lymphomas, lymphocytes were found to be positive, and this was diagnosed on IHC as plasmablastic lymphoma. And next is the left orchidectomy patient. Patient presented with a diffuse large swelling in the testes. So patient was diagnosed as lymphoma. I'll discuss about this patient. Rest all the things like in the previous lecture, sir from the DMC has also showing that there is rare development of the lymphoma in the thyroid. And over here we have seen more commonly this thyroid lymphoproliferative disorders, and we have diagnosed these cases as diffuse large B cell lymphomas. So in all these patients, because large trials are not available, large studies are not available. So over here in our patients, what we have seen was duration was more. These lymphomas were seen in the neglected patients excepting the child age group. Otherwise, like thyroid or any else, like in the spleen and liver, the patient were having this problem from the many years, or duration was more. So some underlying disease may be there for the development of this lymphoma. This was just to show what is happening in the nasal lymphomas. Now, why there is increase in plasmablastic lymphomas? Because EBV infection is more, and Epstein-Barr virus is known for the carcinomas in the nasopharyngeal area, and this is now found to be linked with the plasmablastic lymphomas of the nasal septum. So another case where the testicular biopsy showed lymphoma. In the testes also, there is no association with any virus as seen in the seen in the nasal cavity. There is no association with any H. pylori type of thing, and that is seen in the stomach, and no pre-existing celiac disease as in the small intestine. So in the testes, there is no association with any existing disease, and there is some mutation in the signaling pathways during the cell cycle. So that lead on to lymphomas. It's very, very rare. And the one patient presented to our department with the testicular swelling. And on imaging also, there was no link of lymphoma, diagnosis of lymphoma, as the patient was 65 year old. Obviously, germ cell tumors was not in the mind, but clinical history, imaging studies, and tumor markers were favoring there will be a germ cell tumor. And so that's why left, as we can't perform biopsy on the testes. So without any clinical further exploration of the patient, left high inguinal orchidectomy was performed. And on histopathological examination, what we have seen was uniform cells present on the slide. So those uniform cells can be seen in the seminomas also. Those uniform cells can be seen in the embryonal cell carcinomas also. But we thought, we saw the slides on the multiple reviews. We make a possibility that these are atypical lymphoid cells. There was mitotic brisk activity. But the problem against was these cells were not involving any external part, or the spermatic cord margins were free. Usually in lymphoma, these margins won't be free. So then IHC was applied. In the IHC, primary panel was applied. Primary panel showed positivity for the lymphoid cells. Then secondary panel was applied. And testicular lymphoma, although they are very rare, but they show positivity for the BCL2 and BCL6. We have applied all the markers, CD5, 10, 23, BCL6, cyclin D1, PAN, CK, HMB45 to rule out all the baseline possibilities. But what we have seen that Ki67 was very high. That goes in favor, there will be possibility of lymphoma. So these were the slides. We have seen morphological monomorphic population of the cells, and these I think pathologists can make out if possible. Then these slides look like seminoma testes. So from here we cannot make any clue that this is a patient of non-Hodgkin lymphoma. So then CD45 was applied. So CD45 positivity, the brown color shows the positivity for the lymphoid cell, as CD45 will be positive in the lymphocytes. Then further to classify whether it's T cell lymphoma or B cell lymphoma, CD20 was applied. CD20 showing positivity, so this means lymphoma, and the population is for the B cell type. Now all the markers were applied, all the markers were negative. Unfortunately, BCL6 was negative, 2 was negative, so we couldn't make what kind of lymphoma is this. Then MUM1 was applied. So last marker for the B cell lymphomas, and it turned out to be positive. So the diagnosis of, see, all the markers are negative. And this is Ki67. So diagnosis of diffuse large B cell lymphoma was given, activated B cell type was given. So story यही नहीं रुक रही थी patient की. Patient again presented with pleural effusion. This was a rare case. Extranodal lymphomas are itself rare. Then the case was rare. Then further, that patient has atypical presentation. Patient presented with pleural effusion. So in the pleural effusion itself is very less commonly seen in non-Hodgkin lymphomas. Can be seen in the nodal lymphomas, but it's very, very rare in the non-Hodgkin, extranodal non-Hodgkin lymphomas. So this is the relevantly what I could find article just to show that the massive pleural effusion can be seen in the lymphomas, but in this article also I couldn't get that testicular lymphomas can present as pleural effusion. So patient again was in the ICU, and pleural effusion was sent for the diagnosis. So in the pleural effusion we had atypical lymphoid cell on the slides, and as we know the patient, we thought that these cells may be positive for the lymphomatic cells, but pleural effusion is very, very rare in these patients. So we were little again furious and confused what should be done next. So this is the smear with showing lymphoid cells, and these kind of cells can be seen in the pleural effusion of the tuberculosis patients also. So again, the lymphoid cells, again, we have tried to make this cell block of the patient. We have collected the cells, and we have tried to make with the cell block with the new technique, because we had to make the diagnosis, because it's easy to make the routine diagnosis, but when an atypical presentation with the rare cases it presents, it seems difficult. So on this block, further IHC was applied. Obviously, these cells were CD45. So this slide is from the ICC, intracytoplasmic cytochemistry, and I'm very happy to tell that we have good team in the pathology, and this type of technique is not available in any AIIMS except AIIMS New Delhi. So we are trying this. We have tried this technique, and the patient was benefited with the technique. I'm very thankful to my team. So we have applied CD20 also. It's positive for the cells, for the B cells, and again MUM1, that was positive. The only marker positive in the testicular tissue was positive in the pleural fluid also. So diagnosis was given as the testicular lymphoma infiltrating into the pleural area also. So conclusion is simple. Extranodal lymphomas, they can present as a diverse group of hematological malignancies, and they have various type of presentations, different kind of presentation, different kind of histopathological types, and they have different kind of response to the treatment. As far the treatment is concerned, that they are a bit resistant to the normal treatment that has been given for the non-Hodgkin lymphomas. And most commonly involved areas are stomach and skin, and very rare is the brain and testes. So accurate diagnosis with accurate technique and immunophenotyping is a need of our. and the prognosis definitely is affected by the involvement also. Like if the brain is involved, instead of symptoms from the lymphoma, the symptoms of the pressure on the brain will land up, will cause the poor prognosis in the patient. So external lymphomas, they present unique challenges in the diagnosis and management due to their heterogeneous nature and varied clinical behavior nowadays. So ongoing research into the molecular characteristics of these lymphomas should continue for our understanding and improvement of the treatment. Thank you. Thank you very much. Any question, please? Yes, sir. Yes, sir. Yes, sir. Yes, sir. Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir. Sir, sir, I want to add over here. You have given chance to us that to. You would have conducted this to somewhere else also, sir. So you would have given chance. If you would have not given chance, so how would I? Thank you, sir. Thank you.